should always try all of those things first before getting to the point of needing a knee replacement. But when those things aren't working anymore, when you can't do the things that you really enjoy doing, you can't play with your grandkids, you can't go skiing, you can't go for a walk in the woods, that's when to start thinking about getting your knee replaced.
So are there certain things that would make someone a poor candidate for a knee replacement?
So if you are extremely overweight, that really puts you at higher risk for infections after surgery, or not doing well, that the knee still hurts because of the stresses that you're putting on the knee. If you are a diabetic and your diabetes is under very poor control, you are not a good candidate for surgery. You need to get your diabetes under better control before thinking about having surgery. If you smoke, you need to stop smoking before surgery. If you have problems with the skin on your leg, your skin's really important in preventing infection. And if you have cuts and scrapes on your skin, if you have chronic problems with cellulitis, you may not be a great candidate.
Okay, great. Thank you. So can you tell our audience a little bit about the process of a knee replacement? What goes into it? What happens during the surgery?
Sure. So a lot of people have the misconception that you just cut out the knee and put a new bionic knee in, and that's not really the case. So this is a model of a knee replacement, and it looks okay. There we go. I'm sorry, get it in the camera. And you can see from the side here, it doesn't cut out the entire knee. What it does is resurface it. So there is a metal cap that goes on the femur, a metal piece that goes on the tibia with a piece of plastic in between. And you can see here on the side, or if I take the implant off, you still have a lot of your normal knee anatomy. You keep the ligaments on the side and one of the ones in the back. And when I do a knee replacement, we're making these cuts to fit exactly what the underside of the knee joint looks like. So the surgery actually only takes about an hour to an hour and a half to do. And I tell people the surgery for me is the easy part, but the hard part is the rehab that goes into it afterwards. Most people are able to go home either the same day or the next day, which is a huge change from the last 5 years. In the last 5 years, there's a lot of physical therapy afterwards, but that's basically the surgery.
Great, thank you. So you mentioned, one of the bigger changes is that you go home faster in the last, over the last few years. Is there anything else different about the surgery that's changed in the last 5+ years?
So like we talked about in the very beginning, we're going to talk a little bit about the robotic surgery, and that's something that's really been very innovative in terms of how we do the surgery. It is, people think that, oh, it's a robot, like the robot itself is coming in, like R2-D2 is going to come in the OR and do your surgery, or you're going to be sitting, some of the general surgery procedures, the surgeon's actually not even on the field. They're sort of sitting in the corner somewhere doing the procedure completely on a keyboard, and it's like a video game. In orthopedics, it's really different. I'm still doing the whole surgery, and it's the soft tissues and protecting those ligaments and everything that's really important. I use the computer to help decide exactly where those cuts are on the knee. So these cuts can be made in a slightly different orientation because you want to have a balanced knee so that in both flexion and extension, you have the same amount of space. And in a conventional knee, we use instruments that require you to put implants temporarily into the bone to decide where it's supposed to be. And it works very well. But trying to be more exact, we can use a robot or use the computer to decide and plan those cuts, and then use the robotic cutting arm to make those cuts very exact. So I can probably tell you within 2 or 3 degrees if a line is straight. The computer can get down to 1/2 degree in terms of its accuracy. So it's a little bit more accurate. And the early data shows that the better you put the knee in, the better the outcomes are going to be. So for a lot of people, the robotic knee is really helpful.
That's great. Now, obviously, you do robotic knee replacements here at St. Joe's. How long have we been doing those here for? Do we still do regular knee replacements? I mean meaning without robots?
Yeah.
Do we do a mix? What does that look like?
So it's been just about a year, I think now, since we started doing the robotic knees at St. Joe's. I've done it for longer than that at some other hospitals where they had the robot. And actually the first patient who had his knee done at St. Joe's, who had one of the worst knees I've seen in a very long time, had both his knees were horrible. And then he lost all this weight so that he was able to be a good candidate for surgery. So he had bariatric surgery, and he had his first knee done. He was our first patient. And then recently came back and had his other knee done. He's about 2 weeks out from his second knee surgery. So it's been just about a year. In terms of, do we still do regular knees? And the answer is yes. Some people, for a variety of reasons, because they have a lot of osteoporosis, and the way we do this surgery, you actually put pins temporarily into the bone to allow the computer to know and the robot to know where in space the knee is. If your bone is very soft, that might not be the best option for you. Depending on the quality of skin, it may not be the best option. The other thing is, for some people, I can do as good of a job doing this knee robotically as with conventional instruments. But there's certain people, especially people whose knees are extremely crooked, very knock-kneed, very bow-legged, people who've had previous surgery and might have a metal rod in their femur or their tibia, which changes the orientation of their leg. If they've had previous trauma, so their leg was broken at one point and didn't heal completely straight, those are the really challenging knees to put in correctly. And those are the ones where the robotics really play a huge role in getting the knee right. So for certain reasons, some patients aren't as good of a candidate for the robotic knee as others. So I still do a mix of both.
Yep, that's great. Thank you. And does the robot contribute to the recovery time at all, or is it the same either way?
It seems that patients who have the robotic knee tend to recover a little bit faster, although studies are still being done to see if that's really borne out in large clinical trials.
Okay, great. Now, you actually mentioned earlier that, the biggest change in the last 5 years is that people are going home sooner.
Yep.
So what is the biggest contributing factor to people going home faster than they were 5 years ago?
I think there's so many things that we're doing differently. It's hard to say that there is just one thing. Some of it is expectations. When I started doing this surgery 14 years ago, seems really long ago, we expected people to stay in the hospital 3 days and then go to rehab for 2 weeks. That everyone did it. That was the plan. No one ever deviated from it. And over a period of time, we've said, well, not everyone needs to go to rehab, or maybe we can send people home at day 2 instead of day 3. And so things kept accelerating. And some of it was patients. People are like, why do I have to stay here just to get some physical therapy? I'm doing fine. I want to go home. So patients pushed it a little bit, and then we got better with our surgery techniques. We do nerve blocks before surgery to help control pain. We have long-lasting pain medicine that lasts for about 3 days. So it really keeps you by the time you start having pain, you're already past the peak pain. Do spinal anesthesia. So during the surgery, your body doesn't even experience pain. So you don't have as much of a physiological negative response to surgery. There's a medication called tranexamic acid, or TXA, that we give before and after the surgery, and that reduces bleeding inside the knee. If you've ever hurt your knee and had a really swollen knee and maybe had it drained, you realize that when you have blood inside your knee, it really hurts. And if we have less blood inside the knee after surgery, it doesn't hurt as much. You can bend it better. You just do better. And we've changed the blood thinners that we give people as well. So we give people a little less aggressive blood thinner for the most part, unless they've had a history of blood clots. And that also reduces the amount of swelling and bleeding inside the knee. So there's so many things that we're doing differently. It's hard to pick just one.
So you mentioned the anesthesia. So you said that the surgery only takes about an hour or so. Yep. Are you asleep? Are you awake?
So it depends on your definition of asleep. You do not know what's going on. When you have a spinal, you're numb from the waist down, so your body doesn't know that we're moving your leg around. So we're tricking your brain basically into thinking that you didn't have surgery. And the anesthesiologist will give you a medicine called propofol, which makes you have a really good sleep. It's the same medication people get when they have a colonoscopy, and you don't hear things, you don't remember what's going on. You are really comfortable during the procedure. And then when they turn it off, you wake up and I tell people it's the difference between going to bed and having a great night's sleep, which is what you have with the spinal experience, and as opposed to going out and drinking all night and waking up with a bad hangover, which is essentially what happens when you've had general anesthesia. They've given you a ton of medicine, ton of pain medicine to keep you sedated during the surgery, and you wake up and you feel horrible because of all the side effects of those medications.
So in this case, you don't have that.
Exactly. And so you wake up and you're like, oh, I feel great. I want to go home. And we get you up and you walk in, usually in the recovery room if you're planning on sending you home the same day. And as long as you're feeling okay, and you can go home. Now, there's certain people who live by themselves, who have some mobility issues to begin with, that they really have challenged with balance and coordination, or they have a lot of stairs, or they have some medical issues, and I am not comfortable sending them home because I want to make sure that they do fine overnight, at least that first night. So everyone's a little bit different. So if you need to stay in the hospital, you certainly can. St. Joe's has wonderful rooms where everyone gets their own room, which is really nice. And so if you have to stay, it's not a bad experience at all. I think it's great. But a lot of patients really would like to go home if they can.
So what should people expect in terms of a recovery time? Is this months or weeks or days? So
everyone is different. And I tell people it's not a competition. You can't compare how you did with your neighbor or or husband or other family members who also have had the surgery. And it's a marathon. It's not a sprint. It's not how well you do day 1 or day 2. It's how well you do over the whole process. So everyone is different. Most people take pain medicine for a couple of days to a week, but by 2 weeks are off the pain medicine. You use a walker usually for about 2 weeks, and then switch to a cane when you feel comfortable. By a month to 6 weeks, most people are off the cane and walking normally. You get physical therapist comes to your house for the first 2 weeks after surgery. And then after that, you go to outpatient physical therapy. The most important thing the first couple of weeks is to get your knee moving. So I want to see people being able to bend their knee to 90 degrees by the time they come in for that first post-op visit, because that's really important. Your body's reaction to surgery and trauma is to tighten things up. It's like, oh, this hurts. I don't want you to move it. I need you to move your knee. Because if you don't move your knee the first 2 weeks, that physical therapy and that process becomes longer. So by 6 to 8 weeks, most people are back doing most things, maybe not going for a hike or going skiing. That takes more 3 to 6 months, but back doing pretty much, normal everyday activities. The knee will feel achy and sore for up to a year, actually. There's something magical about a year that it all of a sudden starts feeling better, but people say it's achy, it feels stiff. When I first get up, it just feels a little bit weird. And those feelings can take up to a year, but you see the biggest recovery in the first 6 weeks.
And it sounds like, from what you're saying, that most people can return to normal activities at some point: biking, running, squatting, all those types of things.
Exactly. Well, running, we tell people that you probably shouldn't be running for exercise. If you have to run away from a bear or something like that, certainly it's fine. But if you're running all the time, you're pounding on that knee implant and you will cause it to wear out. And so things like biking, swimming, hiking, even low-level tennis like doubles tennis or pickleball, people get back to all of those things. People ski with their knee replacements. Running's the one thing that I tell people they probably shouldn't do. And majority of people, even though they may want to go back to running, have stopped running a while back because their knee was hurting them. So it's not something that they've done recently. But some people do get back to it. And if you wear it out, I can fix it again.
Well, hopefully not, but yes.
But I want people to get back to doing things. That's the whole point of doing this surgery, is to get you back doing what it is that you enjoy, because there's no point in being retired and having all this time if you then are limited by your mobility and you can't do the things that you really want to do. So that's the wonderful thing about my job, is I give people back their lives. And they say that to me when they come back to see me, like, wow, I can do all these things that I thought I would never do again. And it's great.
That's great. Thank you. So with our last couple minutes here, we just have a couple extra questions, um, specifically more about your practice and when someone's looking for a surgeon, specifically a knee surgeon, is there something they should be looking for in terms of that person's qualifications?
So I think it's really important to go to someone who does a lot of these surgeries. You want, I did a year of extra training called a fellowship, which is a year working. I was at Harvard and worked with some of the people who designed some of these original implants and created knee replacements 30, 40 years ago. So I got the opportunity to work with them and learn from them. So you want to go to someone who has taken the time to do that extra training. Someone whose practice is predominantly knee and hip replacement, because there's plenty of people who do some knees, they do some shoulders, they do carpal tunnels, they do a variety of other things, and they probably do a very good job. But going to someone who this is all they do, you just get really good at it, doing the same thing over and over. There's an organization called the American Academy of Hip and Knee Surgeons, AAHKS, and a lot of us, it's an organization that you have to do a certain number of joint replacements a year to be a member of. It's a national organization. You have to be fellowship trained and board certified. And so finding someone who's a member of AAHKS is a good sign that they are a well-qualified joint surgeon. So.
And obviously, at the beginning, we mentioned that you do quite a bit of work here at St. Joe's. Is there anything unique or special about having your surgery at St. Joe's?
I think those people who are on this, who've been to St. Joe's, there's a special culture at St. Joe's that of really caring. I think that St. Joe's feels like family, and everyone from the person who greets you at the door, even if they're just checking your temperature, making sure you don't have COVID, or the people who check you in the hospital, the nurses in the pre-op and pack you. Everyone likes being here. They work really hard, but they take really good care of patients. They treat them like their family members. And I feel like St. Joe's, despite hospital mergers and all of these things, I feel like St. Joe's really has kept that feeling of family. And I do believe that patients have a very good experience there. And I've worked hard. I'm actually chair of surgery at St. Joe's as well. And I've worked hard to kind of keep that and make sure the patients have a good experience. And if you don't, we want to hear from you, because we want to keep getting better.
That's great. Thank you very much. I appreciate that. And the last question we have for today is, how far out are you booking for knee replacement surgeries?
Yes. So a lot of people come in and they want their surgery done like tomorrow. But unfortunately, it doesn't quite work that way. I'm currently booking out until January. I think there's 1 or 2 people who spots in December, like the day before Christmas Eve, like the 23rd, that might still be available. But a lot of people do want their surgeries done before winter hits, before their deductible ends the end of the year. And unfortunately, this is a really busy time. Between Thanksgiving and Christmas is crazy busy with surgeries for us. But it also does take a period of time to get you ready for surgery. Even if I was booking not so far out, it does take 4 to 6 weeks, because we need you to see your medical doctor. If you have a history of heart problems, I have you see your cardiologist. We do lab work. You see the preoperative nurses and doctors at St. Joe's prior to the surgery, because I want to make sure that you're at optimal health prior to doing your surgery. So there's a lot of things that have to happen beforehand, before you have your surgery. So part of that time period is the preparation.
So the moral of the story is, if you're thinking about getting knee replacement surgery, now's the time to start reaching out, making those appointments, getting those initial consultations to figure out if you're a good candidate.
And there's lots of things. If you're like, I am not ready for surgery, you don't have to have surgery. I'm never going to force you into having surgery or tell you it's emergent. It's not like your bone's broken or sticking out of the skin and you have no other choice. I feel really strongly that you, as a patient, you need to come to me and say, I need my knee replaced. I've tried everything else. Please help me. I don't ever want to convince someone that they need surgery. I think you have to get to that point where you are ready. And when I was a kid, my grandmother's orthopedic surgeon told her she had to wait for the great pain. And she was a bit of a hypochondriac. I loved her, but she would ask us all the time, do you think this is the great pain? Do you think this is the great pain? It was like the running joke in my family was grandma's great pain. But then one day she had the great pain, and it wasn't a question. She didn't ask anyone. She just had her knee replaced, and she did great. But that's what happens. People are like, I don't know, should I, shouldn't I? They're not really sure. The injections are working. These things are working. It's not that bad. But then all of a sudden, it is that bad. And when you know it's time, it's time. But no one should ever try to push you. Your family shouldn't push you into it. Your doctor shouldn't push you into it. You need to know that you're ready, because it is a big commitment. You have to put in the work with physical therapy. It's not like I wave a magic wand and you're better. It's not like the robot just comes in and fixes you automatically. It just doesn't work that way. So you have to be ready to put the time in, to be committed to this, take the time out of work that you need to, focus on yourself, focus on getting better, and you'll do really well and be thrilled that you're able to get back to doing everything you want to do.
Well, that's wonderful. Dr. Hogan, thank you again so much for taking the time today. I know you actually have to.
This is fun.
You have to run off to another surgery right now, so I want to let you go. But again, we appreciate your time. We appreciate all this great insight. And to all the folks watching, we appreciate you taking a few minutes out of your day to join us today. So thank you again, and have a wonderful rest of your day.
Take care.